So there's a little bit of repetition from what I've talked about already at this meeting, talking about combining lung and diaphragmatic protective ventilation. We've heard a lot about lung protective ventilation, so I thought I'd spend the first part of the talk focusing more on the diaphragm and thinking about diaphragm protective ventilation, and at the end, we'll talk about how to put them all together. This is an old paper, but I still like this a lot in terms of a standardized approach to the differential diagnosis of a patient with either difficulty weaning or with hypercapnia, by the way. And it's basically outlines this is the problem of either it's a supply and demand imbalance. Up here, we take an anatomical approach to the patient's ability to do work of breathing. It starts at the brain with the generation of, at the respiratory center, generation of impulses that travel down the spinal cord, into the anterior horn cell, into the peripheral nerve, through the neuromuscular junction, into the muscle, the diaphragm and other muscles of respiration. And on the other side of the equation, you have the amount of work of breathing that the patient has to do, the so-called load that is placed on the respiratory system. And you can divide that up into three big categories: a resistive load, asthma, COPD, small tube, secretions, whatever. An elastic load, anything that makes the lung or chest wall stiff, from pneumonia, pulmonary edema, interstitial fibrosis, big pleural effusions, large tight abdomen. And then importantly, thirdly, a minute ventilation load. So either with high CO2 production or high dead space fractions, you have to breathe more, you have a higher work of breathing. So weaning failure is due to an imbalance of these two things. And I'll blow up the muscle problems are a common cause of weaning failure that can be induced by a number of things listed here. But the important point is that diaphragm dysfunction can be an important contributor to weaning failure. If you want to monitor the muscles of the respiratory system in critical illness, there's a nice review article in the Blue Journal a few years ago from Leo Hunks's group, which goes through all of the different ways you might do this. Just put that there for your reference. The gold standard for measuring diaphragm function would be magnetic twitch stimulation. But as you can see here, it's probably not all that feasible for use in the daily practice of critical care. If you started approaching patients with these magnets that you put on their neck, they might, they and their family members might get a little bit concerned. And there's also technical problems that result. If you don't take careful measure of the changes in thoracic volume, you can get results that are invalid. And it's always challenging to know that you really have achieved super maximal stimulation, which would allow you to really know about muscle function. So in practice, we don't necessarily do this, where we're trying to maximally stimulate the phrenic nerves and see what happens with the diaphragm contraction. There is one paper that I found, though, from Alex Demoule's group in Paris, where they actually did this in the ICU. Again, there may be some caveats with the technical challenges, but when they grouped patients into some control patients, critically ill patients without diaphragm dysfunction as judged by phrenic nerve stimulation, and with diaphragm dysfunction, a big difference in survival and weaning outcomes in these patients. So diaphragm dysfunction is an important prognostic factor here. Just a little bit of a review of the anatomy of the diaphragm. I think most of us think we see the diaphragm on when we look at the chest radiograph, but we're mostly thinking that about this part of the diaphragm, this part here that we see. But really the working part of the diaphragm is this long part down here that you don't necessarily see on the chest X-ray in the so-called zone of apposition. Because really the diaphragm acts like a piston. And when the diaphragm contracts, the dome of the diaphragm descends, creating negative pressure in the chest. And we can look at this on ultrasound. And typically, the classic sort of ultrasound that we would see previously would be to look at, sorry, that didn't show up properly, would be to look at the excursion of the diaphragm when the patients are breathing spontaneously. But more and more, we're actually looking at the diaphragm itself in the zone of apposition here. And here you can see the two layers of here's the pleura and the peritoneum, and here's the diaphragm in between with the liver down here. And in real time, you can see if things move properly. Yeah, here we go. So with the patient breathing, you can see some movement there. And if we put the Doppler probe across that and move into M mode over here, you can see the diaphragm over time. Here's the baseline thickness between A and A. And here's a contraction where the diaphragm thickens between B and B. And so we can calculate both the baseline thickness of the diaphragm and the thickening fraction of the diaphragm, considering how much the muscle is working. And we looked into this to see how reproducible it was, to make sure that the operating characteristics of this measurement were reasonable. And the bottom line is that the right hemidiaphragm, because the liver that is there to give good contrast, is quite reliable as long as you mark the spot and use the same exact spot every time between observers or within observers over time. So I'd say its thickness has excellent reproducibility. There's a little bit more error when we see thickening fraction, just because we're adding another degree of complexity there, but still reasonable reproducibility for thickening fraction in the right hemidiaphragm when measured in the same spot. And so there's lots of things that can cause diaphragm dysfunction, for sure. Sepsis, electrolyte imbalance, shock, other medications, critical illness, neuromyopathy, all can impact the diaphragm. But I'm also going to try and make the case here that the way we use the mechanical ventilator also impacts diaphragm function or dysfunction. A dramatic example of this is from this paper in the New England now 15 years ago, looking at diaphragm biopsies in patients who were brain dead, and therefore brain dead organ donors, and therefore had no diaphragm contractions for about 18 to 69 hours, and contrasting that with patients who were undergoing elective thoracic surgery and had a diaphragm biopsy done during the surgery. And you can see here that there's significant atrophy of the fibers, much smaller fiber size compared to control. And this happened extremely quickly, just in the course of a day or two. ICU-acquired weakness happens in the ICU, but in fact, diaphragm dysfunction is even more common than ICU-acquired weakness. And patients even without ICU-acquired weakness can have diaphragm dysfunction. And it has a much bigger impact on the weaning outcomes of these patients. And how does this happen? Three main mechanisms of myotrauma, we'll say. There's essentially diaphragmatic quiescence or inactivity of the diaphragm, leading to disuse atrophy. There's excessive muscle loading, where the diaphragm is working too hard and causing sacromearic disruption and contractile fatigue. And there's also a potential mechanism through ventilator dysynchrony, when the diaphragm is contracting at the same time that the ventilator is breathing out. And that's a so-called eccentric contraction, which can lead to muscle injury as well. So that's all fine and good, but what does this mean in real life? Well, this is an observational study that we did where we just took patients who were on the ventilator and we thought were going to be on the ventilator for at least a week and measured their diaphragm, both thickness and activity, once a day with ultrasound. And you can see here that there's a group of patients that make up about half the patients where really nothing very much happens over time to their diaphragm thickness. But there's another group, this in red here, which is again about 40% of the patients, which has a rapid decline, loses 20% of the muscle bulk within 3 days. And a little bit to our surprise, we found a third group who had smaller, maybe about 10% of patients, who had an increase in diaphragm thickness over time. You might think that would be a good thing in terms of bulking up muscle hypertrophy, but in fact, as I'll show you later, this was associated with worse function and worse outcomes and likely represents edema and muscle injury rather than helpful muscle hypertrophy. I showed you this graph the other day, this correcting for all these factors. Patients who had normal efforts were the ones that maintained their normal baseline diaphragm thickness. Inactivity led to rapid loss of diaphragm function, excess activity, excess work, increased thickness. I'm just going to skip that slide. So then we extended this study, recruiting more patients, following from clinical outcomes here. And again, this slide I showed the other day, this is accounting for time variant covariates, looking at the change in diaphragm thickness in baseline, and on any given day, you were most likely to be extubated if your diaphragm hadn't changed very much in either direction. And if we look at this in a sort of Kaplan-Meier survival curve here, those with no change from baseline liberated from the ventilator much quicker than those with either a reduction or increase in diaphragm thickness here. Put another way, if we look at duration of ventilation among survivors, a U-shaped curve with diaphragm thickness change, the best duration of ventilation, shortest duration of ventilation here among those with less than 10% change. And similarly, if we look at complications of mechanical ventilation, red is death in hospital, other complications being reintubation, tracheostomy, or more than 14 days on mechanical ventilation. Again, a U-shaped curve with the amount of diaphragm thickness change over time. And the fact that trying to make the fact that this is driven by diaphragm activity is shown in this slide. So the duration of ventilation, again, on the x-axis down here is now not thickness, but mean thickening fraction over the first 3 days of mechanical ventilation. Again, a U-shaped curve where either getting too far away from a normal amount of work puts the patients at risk of prolonged ventilation. So putting all this story together, we have patients with acute respiratory failure who require mechanical ventilation that might be either controlled or partially assisted. The presence of either insufficient or excessive inspiratory effort, as judged by either diaphragm thickening or electrical activity of the diaphragm, leads to alterations in diaphragm structure, and that's mediated by effort. And these alterations in diaphragm structure lead to difficult liberation from mechanical ventilation. It's mediated by changes in thickness of the diaphragm over time. And presumably, although we didn't measure this in these patients, this is through a pathway of impaired diaphragm function. So I tried to show you in this group of slides that there is a growing evidence base that there's a role of mechanical ventilation in iatrogenic diaphragm dysfunction. It's consistent across studies and species. There's possible mechanisms, and there's a biological gradient. We'd like the term myotrauma as a sort of a useful term that's analogous to other forms of ventilator-associated iatrogenesis, volume trauma, barotrauma, that kind of thing. And these are new data that link ventilator settings, to diaphragm activity, to diaphragm atrophy, and to clinical outcomes. So now that we understand the diaphragm better, what about lung protection and combining those two things? The key to understanding lung protective ventilation and why patients get ventilator-induced lung injury is understanding that most patients with ARDS who have a chest X-ray that looks like there's diffuse opacities actually have quite heterogeneous disease when we look at the CT scan, right? When we're doing an X-ray and shooting through all of this, it looks homogeneously white, but in fact, there's areas of the lung that are densely consolidated and atelectatic that are receiving very little ventilation. And there's other areas of the lung, typically in the non-dependent lung regions, that receive the bulk of the tidal volume that you deliver. This is the so-called baby lung concept that Luciano has proposed, where this poor little baby lung up here is receiving twice as much a tidal volume as it's used to, or that you think it is, because this lung down here is not participating. And that's why lowering tidal volume and lowering plateau pressure is useful. I showed this slide the other day as another reference, thinking about all the different factors you have to go into in preventing ventilator-induced lung injury, prioritizing these first probably, and then turning your attention to diaphragm dysfunction. So over-assistance myotrauma, that is, you've checked the patient's efforts and they're not really making much effort, if any. They have very small efforts. If you ultrasound their diaphragm, it's hardly moving. Their P.1 is very low. Their occlusion pressure is very low. How do you treat that? Well, the first thing is to try and reduce support. I put when possible here because occasionally you turn down support and the patients, maybe they're too sedated, they don't actually start breathing yet, so you have to make a few other corrections. But the first thing is to recognize if you're trying to have the patient breathing spontaneously and they're making very small efforts, that's most commonly due to the fact that you've got the pressure support level or whatever mode they're on set higher than the patient needs. And so they're not really contributing to ventilation. If you've tried to titrate this as much as possible, or it's just the patient needs sedation for some other reason and you can't get, it's not safe to have patients making their own efforts. Another possibility that's coming down the pipe is diaphragmatic pacing. This is not quite ready for prime time yet, but there's a device that is in the form of a subclavian intravenous catheter that usually gets inserted here, goes across, and has two different electrical arrays and captures both the left and the right phrenic nerve as it goes along. There's lots of data using this in a pig model showing that you can stimulate the diaphragm and have normal activity. And we've just started using this in a first in humans trial for acute respiratory failure. This is a case series of the first 5 patients that we've done. And showing here, so this is airway pressure, tidal volume, flow, and then, sorry, this is flow, tidal volume, airway pressure, gastric pressure. So when the on-demand pacing is active, you see a activation of the esophageal pressure, negative esophageal pressure. Then when the pacer is turned off, you don't see these negative deflections anymore, just showing that it actually is doing what we think it is, stimulating the diaphragm. And in 5 patients here, where the idea was when the diaphragm is not making it, when the patient's not making any efforts, we stimulate. If the patient starts making efforts, we don't stimulate. Most of the time, we were able to be in the green, where patients, this is no respiratory drive and stimulating happening. Blue was patients making efforts and we're not stimulating. That's the way it's supposed to work. So only for a few hours here was there respiratory drive absent, but the stimulator wasn't working for whatever reason. So this is a case series that we've put together now up to 20 patients and extending up to a week of mechanical ventilation. Next will be a sort of phase 2 trial to say, does this actually impact clinical outcomes, at least from a physiologic and feasibility aspect? Treating under assistance myotrauma, i.e. the patients have larger efforts than you want, can be more tricky, especially when we're prioritizing ventilator-induced lung injury, because we might be able to say, okay, let's increase inspiratory assist to try and dial down patient efforts, but that's going to still lead to high tidal volumes, overall large distending pressures. We talked yesterday about titrating PEEP, also FiO2, using sedation, principally with propofol. And we talked yesterday about using partial neuromuscular blockade or extracorporeal CO2 removal. Whether it's actually possible in very severe patients to achieve lung and diaphragmatic ventilation at the same time, I don't really know yet. It's tricky. That's what I'll tell you for sure, especially if you're picking quite severe patients. This is a pilot study that Jose Diente, one of our international fellows, led, and essentially took patients who had severe hypoxemic respiratory failure and tried to get them inside that happy box of both lung protective and diaphragm protective mechanisms, using a technique here where they were randomized to PEEP titration first and then sedation titration second. And the results are shown here. So in 30 patients, the interesting thing to find is that at enrollment, none of them were in the happy box of both lung and diaphragm protective ventilation. They were all sedated and none of them were making any respiratory efforts. Probably because as soon as they titrated down sedation to initiate spontaneous breathing, almost all of them, in both the patients not on or on ECMO here, the vast majority had very high respiratory efforts that put them outside of the safe lung and diaphragm protective window. After higher and lower PEEP and titration, in patients not on ECMO, only a minority were able to be, maybe about half were able to be inside the safe window. Much easier when patients were on ECMO and we could titrate and reduce drive using CO2 removal. So this is why we're still in the feasibility stage of assessing protocols to address this. It may not be that easy to do in many patients, particularly those with the higher degrees of severity. Okay, so I've tried to show you, I didn't talk about this that much this talk, but we've talked previously that the intensity of mechanical ventilation is important. And in addition to standard tidal volumes and plateau pressures, you might want to start thinking about driving pressure, delta P. I think it's reasonable to start with 6 mils per kilogram and then adjust further according to if your driving pressure is very high. We talked yesterday about combining and considering both machine and patient efforts when you're assessing the intensity of mechanical ventilation. And I'd say that after you've minimized ventilator-induced lung injury, then you can turn your attention to avoiding ventilator-induced diaphragm dysfunction. And with that, I'll stop and thank you for your attention.